All right, this is where we left off, right? This is quick. This is just to finish up our intro to the heart, cardiology. It's called the refractory period. In the you see the EKG complex down here. This should look familiar to you. And then this action potential here in the heart with its electrical system has a period of time where it can't receive an outside stimulus. Okay? So this, where it can't receive the outside stimulus, is called the absolute refractory period. The way that I remember that is so you can absolutely not accept an outside stimulus. If you read the direction of the thing above, it says the ARP, absolute refractory period, does not allow for any depolarizations. So it won't, the cell won't depolarize. Okay? Then you have the ERP, may allow some depolarization. Okay? And then relative refractory period allows a stronger than normal stimulus, like defibrillation or like a synchronized cardioversion of some sort. Okay, and we'll get into that later. We're just picking up definitions now. Okay, supra, above normal period, is hyperexcitable when even a weak stimulus can cause an action potential. So this period right here, this supranormal period, okay, a weak stimulus can cause an action potential or depolarization. So now we have a heart that is sinking, ba-boom, 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 ba-boom. If we receive an outside stimulus, okay, from that, then it could cause an irregular heartbeat, and from that irregular heartbeat, the patient could go into ventricular fibrillation. Did y'all learn that in CPR last year, ventricular fibrillation? Nah, don't worry. It's coming up. You'll be very familiar with that. Ventricular fibrillation is the most common heart rhythm in sudden cardiac arrest. But that's for later. Just give you a tidbit for later. Okay? So it's a weak period here. A weak stimulus can do this. In theory, if you were to lick the battery, a 9-volt battery, you know, that's how you test, see if a 9-volt battery is good, right? You lick it, you go, oh, yeah, that's good. It tingles your tongue. Okay, it shorts across the saliva in your tongue. And in theory, that during the normal period can cause a depolarization, or can cause a skip beat in the heart, perhaps. Okay. Now that's in theory. That's sort of out there, but it's possible because it is a weak stimulus. Now, where more stimulus is if you were to take your fist like so, and on a patient, go down and hit their chest like this. You go like that on their chest. That's called a precardial thump. Used to, I don't have to double check, but used to in a witnessed cardiac arrest, okay, the person would give a precardial thump. So if I clenched my chest here, fell over, pulseless, apneic, I'm in cardiac arrest, you witness that, you would walk over and go from about here, not like from downtown, but just a good thump. That thump delivers 6 joule watts. It's a form of energy that we'll speak of when we do CPR, but it delivers 6 joule watts of energy approximately. Okay, so that heart would during this period of time could receive that stimulus. Does that make sense to everybody? Back when I was in school, way back in the day, we sort of abused freshmen. I didn't think it was abuse. Teachers, staff didn't either. But a freshman would, the fish, they would walk down the hall, and if they had their books down like this, you can tell the freshmen, right? Ones that look lost, or the ones that think that they have to have all this attitude to prove something. Anyway, upperclassmen, if there was a freshman walking down the hall with his chest open like this, the upperclassmen would take their fist and go, bam, right in the middle of the chest. I mean, hard. It was just a rite of passage, okay, back then, and they would, we'd do it right in front of the teachers. And the fish would be looking at the teacher, and goes, "You must be a fish," and they just go on. Just a rite of passage that we did, okay. Back then, we didn't realize, hey, that's actually enough energy, especially as hard as we hit them, enough energy to disrupt the normal electrical pattern of the heart. They could have dropped dead right there. They could have dropped into ventricular fibrillation. Anyway, back in the good old days, okay? So that's just sort of what we're talking about there with the heart picking up that stimulus. Here's just another graph where it shows absolute refractory period here and relative refractory period here. It only shows the two. And that's really the only two that we look at. That supranormal period is here. And now where this is going to come into play is when we talk about synchronized cardioversion. Probably about 7 weeks-ish. Okay? So we'll refer back to this in about 7 weeks when we talk about synchronized cardioversion, because what it does, the monitor synchronizes the R wave right there, and it actually puts a little dot on the cardiac monitor and synchronizes it so it can deliver energy in this relative refractory period, so the heart can receive stimulus. Now, we're talking the normal stimulus, not like a lightning bolt. Okay, a lightning bolt hits a person, that's going to disrupt the heart. All right, even if they're in their absolute refractory period, that's thousands of volts, so it's going to do its thing. The other thing that we'll look at briefly is the EKG paper, because of the fact that we need to know. We're eventually going to measure these things, measure rate. So when we look at EKG paper, this is one big box. See how it sort of dragged it down there? And it's referred to, when we do EKG interpretation, it's referred to a big box and little box. Okay? So this is a big box, and every square on the big box is 0.04 seconds in time going across. So 5 big boxes would be 0.20 seconds. It's important on the time. Everything, by definition, has a time attached to it. And then here is amplitude in millivolts, and we'll also put a slash there in millimeters. Okay, so one little box is 1 millimeter, and that becomes pertinent when we talk about heart attacks, MIs, acute MIs. Okay, STEMIs. Remember that we brought up STEMIs before of the class, so that becomes pertinent. So just sort of keep this for later, and we'll look at that. But I wanted to introduce it now, so when we're talking about big box, you can sort of start putting those times away and amplitudes away, and think about time and amplitude, and not millivolts for us, but millimeters. Okay, and then time. And then there's just this QRS complex that we talked about, and there's the times. So a normal QRS complex is 0.08 to 0.12 seconds. So this thing can't be any wider if it's normal than 3 little boxes. Do you guys see that? So if this is greater than 3 small boxes, it's considered a wide QRS complex. And we'll get those definitions later. We're not there yet. But that's where the times come in. EKG interpretation is about understanding the rules of interpretation. Like a P wave, is upright, well rounding, proceeding, and the times here will play a little bit more important role later. Good. Off the heart, onto something else, right? The lymphatic system, we don't spend any questions there before we move on? We're all good with the heart? Okay. The lymphatic system, we don't really spend a lot of time. It captures fluid, it maintains the fluid balance, it helps with infection, okay? You have lymph nodes in a bunch of different places. You notice when you go to the doctor and the doctor palpates your neck, right, to touch. We talked about palpate before, that word. Are you all familiar with it? Okay, so palpate or to touch, they palpate the neck. They're feeling up here in the neck, right? They're feeling those lymph nodes. You see if those lymph nodes are swollen. Usually people have swollen lymph nodes when they're trying to fight off infection. So they feel around in there. There's lymph nodes everywhere. So they feel for those lymph nodes. So the lymphatic system sort of filters a little bit, and you have the tonsils and spleen, okay? And we don't spend a lot of time here because it's just, if we were teaching maybe cancer or something, we would talk about oncology, then we'd spend more time with them in the lymph nodes, in the lymph, but we don't. So we move on, okay? When we look at this, do avoid, bring this back up when we do vital signs, but avoid taking a blood pressure and a mastectomy, okay? Someone who's had breast cancer and had a breast removed, then you wouldn't do a blood pressure over there. Don't worry, because they're going to tell you before. They're going to say, hey, you can't do blood pressures in my right arm. They may also be a renal patient. They may have a shunt there. You can't do a blood pressure in an arm with a shunt. And again, we'll talk about this when we talk about vital signs. You'd be happy to know I fixed the mouse. Gives a low battery. Did I speak too soon? No. I still have control over it. Not much control, but better.
The respiratory system moves air through the nose, pharynx, larynx, trachea, and bronchus to the alveoli, where the gas exchange between oxygen and carbon dioxide occurs. Nares are the openings to the nose capillaries. The air is filtered by cilia, moistened by mucous membranes, and warmed by the blood. Air moves into the pharynx or throat, the common passageway for food and air. Air continues on to the larynx. The epiglottis, a flap of tissue in front of the larynx, closes off the larynx when swallowing to prevent food from entering. The larynx, or voice box, contains the vocal folds. The trachea, or windpipe, connects the larynx to the bronchial tree. The cartilage rings of the trachea prevent the trachea from collapsing. Lungs are spongy tissue with alveoli and blood capillaries. Breathing occurs because of the expansion and contraction of the lungs. The bronchi, carrying the air, subdivide into smaller branches called bronchioles. At the end of each bronchiole are the alveolar sacs. The alveolar sacs are surrounded by blood capillaries and contain millions of single-layer alveoli cells where the gas exchange takes place. Oxygenated air goes from the nose to the pharynx, larynx, trachea, bronchus, and alveoli. By the process of diffusion, oxygen in the air moves from the alveoli to the capillaries. Carbon dioxide moves from the capillaries to the alveoli and is exhaled. This process is called respiration.
All right, very quick sort of intro. All right, I mean, we'll talk about all this stuff beforehand. But any questions on what's called a bronchial tree? Yeah, I mean, if you looked at this, if you flipped it up, it would look like a pretty cool looking tree, right? So the bronchial tree, the question is, when you get into medicine, you won't eat certain foods because they look like certain things, okay, that you suction perhaps. Is that brisket or lungs? What would you think? Does that look like brisket or a lung? Because there's a lung.
Oh, okay.
Brisket or lung?
There's that one thing over there, it's dry.
Yeah. Picture of it, because it does. So it looks like a dried up lung. Okay. Of course, I told everybody that, and I had more brisket to eat because people didn't want to eat it then. I don't understand why. All right. But this just shows. This is a picture of the great vessels in the lungs. We have obviously 2 lungs. You can live without a lung. You just can't breathe very well with one lung because there's divided into lobes, right? So we have 3 lobes on the right, 2 lobes on the left. Why 2 lobes on the left? Yeah, you have the heart on the left. I'm not sure what that cardiac notch you're talking about is. Okay, so your heart is on the left, so your heart takes the space of 1 lobe. All right, in between here, this space in between here, it's called the mediastinum, or the middle. And then there's a real lung that's been in formaldehyde, so it's a little pickled. Okay, but we'll look at that when we go to UT Southwestern. We'll pick up the lung and hold it and get to see some that are just on the norm. Okay. So when we look at the just like the cardiac circulatory system, it has a certain function. The respiratory system has a certain function. It is to take air from the outside, bring it in, and go down to the hardest word in the world, alveoli, okay, which is many, right? Alveoli is a many. Alveolus is 1. Is that correct? Yeah. Okay, so spelled by phonics, alveoli. Okay, so you have that. It brings air down to the alveoli, and then through the process of diffusion, that oxygen goes into the capillary beds and then is pushed out to the cells in the tissue, right? And then carbon dioxide is excreted. Carbon dioxide would be a waste product. Now, breathing air in, inhalation, also has a different word too. Inhalation, we breathe air in, is ventilation. So when you ventilate a patient, you're taking air from the outside and you're breathing it in. Okay, that's ventilation. The process that takes place in diffusion is called respiration. Respiration is where the gases exchange. Okay, so understand those two. Ventilation is taking air from the outside and bringing it into the body. Respiration is at the gas exchange level in the alveoli. And then I'll make you a bigger copy of this because you need to know what is consistent in the upper airway and what is the lower airway. The upper airway is the naso and oral pharynx. Remember that picture we looked at? That cross-section of the head. And then the epiglottis into the larynx. Below the larynx is considered the lower airway. And of course the pharynx is the throat, correct? So we have the pharynx, the nasopharynx, the oral pharynx, the epiglottis, and the larynx. The larynx is where the vocal cords are housed. Below that we have the trachea. The trachea is about 21 centimeters long in a normal size adult, and then it bifurcates. Bifurcate meaning what? 2 by 2. It bifurcates into 2 directions. Bifurcation is splitting off in 2 directions. Okay? At the and then it forms into the bronchus, the right bronchus and the left bronchus. And this part right here, we're in the middle. So you have where it bifurcates. This part here is called the carina. Carna. You spell by phonics like I do. Okay, carina. Pretty sure that's how it's. Is it spelled right?
It says carnea.
I think that's how it's spelled.
Carina. Yeah, carina. Check it. Somebody check it. Ask Google. They know.
It's carina, yeah, carina. That's spelled
Carina.
wrong.
Is that the way it's spelled?
No,
Switch the
it's
N and the I.
C-A-R-I-N-A.
What?
Switch the N and the I.
Yeah, there you go.
So that's wrong?
Yeah.
Okay. Carina. Okay. So you have carina, then it breaks down, and then from there it goes into the bronchial. Then the bronchioles have they split off. What did Khan say? How many times? Y'all remember that? There's so many splits from the bronchus. There's so many different where it splits off. Don't hold me to the number, but I believe it's 27. Okay, there's 27 different splits off, and it becomes smaller and smaller and smaller and smaller. Okay, once it gets here to the terminal bronchial, sort of right before the alveolus, before it right gets here, a little oxygen exchange takes place in that terminal bronchial. But that's just trivia, okay? We're going to focus more on the alveolus where gas exchange takes place. The air goes in there, and the process of diffusion, it's everybody good on the anatomy of the respiratory? So the upper airway is from the larynx up, and the lower airway is from the larynx down. Okay? And so when gas enters in, let me see where I'm going here. Hang on. Okay. Okay, this is where I do it right here. When we want to breathe in, okay, it's the body. Now we're talking about two different systems here, okay, that we have to think about. We have the mechanical part of breathing and the sort of what I call the brain part of breathing, the neurological part that the brainstem controls, okay. So we have to split those into two sections. So what happens is the body decides it needs to breathe. We'll get to that in a minute. Okay, so the body decides that it needs to breathe. It's going to send the signals down to the breathing muscles, okay, and they're going to start contracting. And what takes place is that once those signals come down, the diaphragm, all right, contracts, and the diaphragm contracts in a downward motion, okay. It sends signals to the intercostal muscles, the muscles between the ribs, and those contract, pushing the chest wall outward. So the first part of inhalation is where the diaphragm contracts in a downward motion. The intercostal muscles push the rib cage outward. Okay, what is this doing? Downward motion, outward motion. What's that doing to the thorax? Making it bigger, right? It's expanding it. So the container is bigger, correct? Now you have a bigger container. So you have a pressure. You have atmospheric pressure out here, which is what we will talk about at sea level. Is 760 millimeters of mercury. This is just what it's measured in. pressure. We'll talk about that more when we get to vital signs. But if we were at if we were at sea level, the atmospheric pressure would be 760. We need that number for me to finish explaining this, okay? So what happens is there's an intrathoracic pressure. There's a pressure inside our thorax. Intrathoracic pressure. Now for that gas to move, that gas has to move from a high concentration to a low concentration, correct? Okay, so if I have an intrathoracic pressure of, I don't know, let's make up a number, 10. That's not it, but 10, okay? I have to have a bigger container. I have to drop the pressure less than atmospheric pressure, correct? Maybe this will clear it up. Let's say, hypothetically, this is a chest wall, okay? Let me put arms out. So you can, yeah, that looks better. Okay. So this is here. Let's say this intrathoracic pressure is 762. Okay. That's a random number. Okay. Now I have 762 millimeters of mercury inside my chest, 760 on the outside. So the gas is not going to come in until when? Until I drop this intrathoracic pressure lower than 760, right? It has to be lower. The intrathoracic pressure has to be lower than the atmospheric pressure in order for air to come in. Everybody agree with that? Because of that gas law, that gas moves from a high concentration to a low concentration, correct? Everybody good with that? Okay, so when I expand my thoracic cavity and drop that down, it makes this container bigger, correct? If I don't change the volume in a container, but I make it bigger, what happens to the pressure inside the container? You said it, just it drops or decrease. Use the word decrease. So when the body contracts and pushes the chest wall outward and the diaphragm goes downward, it decreases the intrathoracic pressure below atmospheric pressure, and then air will come in. Does that make sense? Because now my container is bigger, so air will come in. When will air stop coming in? No, if it's higher than it's going to come back out. When will it stop? Right, in theory, okay, it stops when it intrathoracic pressure and atmospheric pressure will stop when it becomes equal. Okay, we don't quite get there because the body won't take that much air in. Okay, we don't become equal. What happens in next? Okay, the air comes in, the lungs expand. Right, there's stretch receptors on the chest wall. Okay, that's telling the body, hey, that's enough. That's enough. So it sends a signal to the respiratory centers in the brain saying, that's enough. And so it sends a signal down to relax those muscles. Make sense? So now the signal's coming down and it's relaxing the muscles of the thorax. The diaphragm comes back up. The intercostal muscles relax and the chest wall comes back down. Can you visualize that? Okay. Now I've made the container what? Smaller. Very good. I made the container smaller. Without changing the volume, and I make the container smaller, what happens to the pressure? Very good. It increases. Does everybody grasp that? That's hugely important to understand. So when when ventilation begins, the body says, hey, I need a breath, okay? Sends that signal down, the diaphragm contracts, the intercostal muscles of the chest pushes the chest outward, causing a larger container, causing the intrathoracic pressure to fall below atmospheric pressure, and air will come in. Air will continue to come in until the body signals, hey, that's enough, okay? And then the diaphragm's going to relax, the muscles of the chest wall are going to relax, the container becomes smaller, increasing the pressure above atmospheric pressure, right? And then we exhale. Inhalation is considered active. Exhalation is considered passive. It's considered passive because the relaxation of the muscles. It's considered active because of the contraction of the muscles. Does everybody see that? That is very important to understand, to get this part down. Don't worry, we'll go over it again and again to make sure everybody has it, because it's critical that you understand that. Now, some terminology that we have to have. Do y'all want to take a picture of this while you exit? I mean, for your refrigerator?
I'm down.
Okay. Anyhow, that big breath of air that we take, that big breath of air is called tidal volume. Tidal, not tidal like your car title, okay? Tidal volume. The average tidal volume for an adult is 500 milliliters. That's important. So the average tidal volume for an adult is 500 milliliters. What will take place is when I take a breath, I go, and I'm not the average size adult, I'm smaller, but so I go, but on the average size adult, that I just breathe in 500 milliliters. All right? That's called tidal volume. We want adequate tidal volume, meaning that we want that person to be able to take a deep breath. Correct? That's very important because later we'll run into patients who can't take a deep breath. So their tidal volume is decreased. We just need to sort of get a fix on this word here and what it means. So the tidal volume is the amount of air, the average amount of air with inhalation. What about this air that we're inhaling? It has oxygen in it, right? What's room air? The room air is abbreviated RA. Room air. What's room air percent of oxygen? Does anybody know? Do you remember? We taught this. You took biology, right?
Yeah.
21%. Okay, so we breathe in 21% of oxygen. Okay? What about the other part, nitrogen? Well, it might be 78%. Okay? And then you have some other stuff to figure up the math. We breathe in more nitrogen than oxygen. And the nitrogen is responsible for DNA. It helps with DNA and some other things. Okay, but we're focused on the amount of oxygen that we breathe in. It's 21%. We exhale 16%. So do the math. How much oxygen does the body actually use? 5%. We only use 5%. So not that 5% very well. Okay. So we exhale 16% when we look at this in this whole respiratory cycle. Does everybody understand the mechanics of that? That's something that you have to sort of visualize and work on. Other things that that we will look at in a minute, I want to actually come back to this. Nope. And go over here, okay? Because what takes place here, here's the standard picture for the capillary bed. Picture an alveolus right here, right? That grape, that big old grape with this covered with this capillary. All right, so blood flows, comes back from the superior vena cava. It's going back to the heart, goes through the right atrium, passively fills the right atrium until the pressure builds up, and then the valve opens. The what valve? The tricuspid valve opens, goes in the right ventricle, pressure builds up. What valve opens? Pulmonic valve opens. It goes to the pulmonary what? Artery, because it's taking blood away. Goes to the lungs, reoxygenates in this capillary bed, and is returned back to the pulmonary vein, blah, 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 right atrium, mitral valve, or aortic valve to the body. Okay? But here we are here in the lung, and this alveolus is sitting right here. So we're having deoxygenated blood come down through here and passes over here. We just took a breath. Remember the heart, we're talking in cycles, right? So we just took a breath. This alveolus is full of oxygen. Sort of. Has some carbon dioxide in there as well, but it's full of oxygen. Let's just do that for now. This is full of oxygen. This gas here that's coming back from the little toe is low on oxygen. So this is low on oxygen. This is high on oxygen. What is this high in? What is this bringing back? Very good, carbon dioxide. So it's high in carbon dioxide, low in oxygen. This is high in oxygen, low in carbon dioxide. Move out here, correct? These two gases are going to do this. They're just going to transfer out. It's like walking from, let's say I'm in the capillary bed here, and that's the alveolus. I'm the bad gas. I'm carbon dioxide, and I do this. And the oxygen sitting in here now, it's like, can't stand you, carbon dioxide. And so it goes into the bloodstream. It literally does this. You've seen the animation, right? And so it does this all the time. All the time. It's diffusing all the time. Okay? So that's diffusion. That's the process of diffusion. Now this is everybody good with that? So because it's a difference in pressure. Now I'm going to introduce something before we take a break, okay? It won't be pertinent for a few weeks, but I want you to have it in your notes. Is that there's this capillary bed is not laying directly on the alveolus, the one. There's a thin layer of water there, or fluid there in between. So you have the big Al sitting there, the alveolus, right? And there's a thin layer of water or fluid that is there, that air has to go through. That'll make a lot of sense when we start talking about congestive. That the alveolus, if I remember right, is that thin. 25 micrometers thin or thick. It's incredibly thin. Okay? That's 25 with 6 significant figures. 2, 3, 4. 1, 2, 3, 4, 6. Yeah. That's how thin the alveolus is. Anything that gets in the way of that fluid, for you guys who light it up, smoke, tar, whatever's in the lungs, okay, snot, whatever's there, okay, is going to decrease the amount of diffusion that takes place. Now, fortunately, We have a bazillion of these, or billions of these, so we can still diffuse.
Layer of fluid, is that where pneumonia can develop from?
No, pneumonia is an infection inside the bronchial tree somewhere. Yeah, we'll talk about pneumonia when we get there. But no, that's different. Just everybody good with that? Keep that understanding that, hey, it's thin, and that anything that gets in the way is going to decrease diffusion. Smoking is the big one. I pick on smokers a bunch because it's so bad. There it is here the mediastinum where the heart is, the two lungs. Okay. We just talked about that. Okay. Don't look up, you'll have a seizure. Alright, right quick. Getting up there. But the normal CO2, just so we have numbers down, is 35 to 45. We breathe in response to carbon dioxide levels, not the need for oxygen. So carbon dioxide levels above 45. We breathe in response to that. The body is saying, hey, we need to get rid of this carbon dioxide, and the way that it does it is it exhales it. 8%, okay, 500 milliliters of tidal volume. I don't know why that's there. Maybe I needed spellings or something. This are tendons that connect to the valves. So when the pressure builds and the valves open, those chordae tendineae are connected to the top of them, and the bottom is connected to the papillary muscles, and the papillary muscles will contract and open the valve. And then here we are in the mechanical side of this. This triangle is change, right? Remember that from chemistry? Change in pressure. We change the size of the container. So this is going to take a little bit more time, and you guys need a break. All right. But we breathe on, remember, we breathe on a response to an increase in CO2, and this is called the hypercarbic carbon dioxide, hypercarbic drive. Later, when we get into respiratory emergency, we'll learn about the backup drive, which is the hypoxic drive. Y'all know that spelling? Hypoxic. Hypoxic drive. Okay. These things take place, these chemoreceptors that are in the arch of the aorta, and hold a moment. Anyway, you have chemoreceptors that receive the information about the buildup of carbon dioxide. I know that they're in the arch of the aorta, and somewhere else I have to look and break. So chemoreceptors measure the levels of carbon dioxide, and once they become too high, then this breathing process starts. Okay? And it starts here at the neuro. This is where we'll pick up after break.